The topic of our lecture today, congenital heart disease. The causes of congenital heart disease are unknown in 90% of cases. They are very likely multifactorial with genetic and environmental inputs. Near 5% of cases are associated with chromosomal abnormalities. Less than 1% of congenital defects are clearly environmental. Maternal rubella in the first trimester, excessive alcohol consumption, excessive cigarette smoking, and thalidomide using. Some words about thalidomide. A sedative and hypnotic commonly used in Europe in the early of 1960s and developed to cause serious congenital anomalies in the fetus. Now used in the treatment of erythema nodosum leprosum. The most critical juncture is embryology cardiac development in gestational weeks from 3 to 8. Clinical consequences. Children with significant congenital anomalies have hemodynamic sequelae, failure to thrive, retarded development, cyanosis. Increased risk of chronic or recurrent illness, infective endocarditis, due to abnormal valves or to endocardial injury from jet lessons. The various congenital anomalies are two types. There are shunts and obstructions. Shunts denotes abnormal communication between heart chambers, between vessels, or between chambers and vessels. Depending on pressure relationships, blood may be shunted from left to right, more common, or right to left. Right to left shunts, cyanotic congenital heart disease, cause cyanosis from the outset as poorly oxygenated blood passes into the systemic circulation. They also permit emboli from venous sources to pass directly into systemic circulation. Paradoxic embolism. Left to right shunts include chronic right heart overload with secondary pulmonary hypertension and right ventricle hypertrophy, but eventually right-sided exits left-sided pressure and the shunt becomes right to left. Cyanosis appears late. Once significant irreversible pulmonary hypertension develops, the structural defects of congenital heart disease are considered irreversible. Secondary findings in long-standing cyanotic heart disease include clubbing of the fingers and toes, hypertrophic osteoarthropathy, polycythemia. Obstructions typically may be coarctation, valvular stenosis, or atresia. These do not cause cyanosis. Left to right shunts with late cyanosis. In this group, we include atrial septal defect, ventricle septal defect, and patent ductus arteriosus. Atrial septal defect. Definition. A secundum atrial defect is a hole in the septum primum at the site of the foramen secundum, not covered by the septum secundum. Anatomy. The defect is high in the atrial septum and may vary from dime size to virtual absence of the atrial septum. Physiology. In the vast majority instances, the shunt across to defect is from the left to right atrium in diastole. The two atria act as a single filling chamber with identical pressure if the hole is at least 1 cm in diameter. The flow in diastole is towards the ventricle chamber, which is thinner walled and more compliant, right ventricle. Physiology. The pulmonary atrial pressure is normal in spite of the high flow. owing to the distensibility of the normal pulmonary arterioles. Increased pressure walk is a late phenomenon if arteriolar obstruction appears, at which time the shunt becomes bidirectional or even at right to left. Pulmonary hypertension. Diagnosis. Patients with secundum atrial defect do not become symptomatic until childhood or adolescence. This phenomenon may explain the late discovery of the malformation. The symptoms consist principally of failure to thrive, dyspnea, and palpitation. Physical examination. Patient is usually a tall thin girl, almost from 2 to 1. Cyanosis is rare and almost invariably indicates right ventricle outflow tract obstruction, pulmonary stenosis, or pulmonary vascular obstructive disease. Jugular veins are strongly pulsatil. Left chest prominence. In auscultation, the first sound tends to be loud. Almost pathognomonic feature is widely split second sound with a pulmonary closure of normal intensity, barely moving with respiration. Auscultation. There is a soft ejection murmur at the second left interface, louder if there is associated pulmonary stenosis, and a low-frequency early diastolic rumble at the lower left sternal border. The sounds, the murmurs, and palpable impulse with left chest prominent all indicate a hyperkinetic circulation. Electrocardiography picture. We can see right ventricle hypertrophy. Severe right ventricle hypertrophy indicates obstruction of the right ventricle outflow tract. Radiography investigation. The chest film shows mild to moderate right ventricle and right atrial enlargement with pulmonary vascular engagement and a prominent main pulmonary artery segment. The sinus venosus defect is characterized by the absence of the right superior vena cava shadow and entrance of the horizontal pulmonary vein into the right upper cardiac shadow. Echo-Doppler study. The Doppler echocardiogram, particularly in color, gives a good estimate of the size and direction of the shunt. A warning note should be sounded here lest a patient be referred for surgery on the basis of a false positive echocardiogram without supporting data from the physical examinations, chest film, and electrocardiogram. Management. It has been to close surgically all clinically significant secundum atrial defects anytime on diagnosis. Patients operated on in childhood and early adulthood may look forward to normal lives. Ventricle septal defects. Definition. An opinion in the ventricle septum that allows communication between the right and left ventricle. Anatomy. The defects are of variable size and may be located in any part of the ventricle septum as single or multiple lesions. Locations of ventricle septal defects may be muscular, defect in the lower trabecular septum, perimembranous, or subpulmonary. Physiology. A ventricle septal opening allows shunting of left ventricle blood into the right ventricle. The amount of shunting depends on the size of the defect and the relative pulmonary and systemic resistances. A large left to right shunt is associated with increased water in the lung, accounting for the symptom of tachypnea. Diagnosis. A ventricle septal defect is most often detected by the discovery of a murmur on routine examination. The absence of a murmur at birth and its appearance a few days later is characteristic of ventricle septal defects. By contrast, the murmur of infundibular pulmonary stenosis, which is virtually identical on auscultation, is heard at birth. Physical examination. An infant with a small ventricle septal defect and other cardiac problems appears normal. There is loud murmur, usually loudest at the lower left sternal border. The infant with a large ventricle defect is often scrawny, with discordant height and weight, also both measures may be below the 5th percentile. Tachypnea is as high as 100 beats per minute is common. Peripheral pulses are small. Liver is often enlarged. Cardiac impulse is visible. In auscultation, pansystolic murmur, loudest at the lower left sternal border. Without treatment, the heart rate is fast and a gallop rhythm may be present at the apex. The gallop sound is diastole at a fast heart rate, may become a mid-diastolic rumbles as the heart shows with digoxin therapy. Pulmonary rhonchi and rales are common. Electrocardiography. In the patient with a small ventricle septal defect, the electrocardiography is normal. With increasing larger defects, there is first left ventricle hypertrophy, and then, with the largest defects, both ventricle hypertrophy. Radiography. Both the heart size and the pulmonary vasculature are normal in infants with small ventricle defects. With larger defects, the heart is proportionally large, with increased pulmonary vascularity. The left atrial shadow may be large. Pneumonitis, atelectasis, or aspiration may be evident. Echo Doppler study. A Doppler search for additional associated ventricle septal defects should be made in all cases. Differences between right ventricle and left ventricle pressure are recorded, and possible pressure gradients between the right ventricle and pulmonary artery are estimated. Management. Small ventricle defects. The majority of patients with ventricle septal defects are and remain asymptomatic because their defects are small. Only 50% of all patients with a ventricle septal defect require surgical intervention. Even among the symptomatic infants, only 30% come to surgery. Management of the large ventricle defect. The most common problems are congestive heart failure and failure to drive. Congestive heart failure is managed initially with digoxin and diuretics, but only rarely is there more than minimal relief of symptoms. Surgical correction is desirable before right heart overload and pulmonary vascular disease develop. Patent ductus arteriosus. Definition. In the fetus, the ductus arteriosus permits blood flow between the aorta, distal to the left subclavian artery, and the pulmonary artery. At term, and under the influence of relatively high oxygen tensions and reduced local Prostaglandin sensitizes muscular contraction closes the ductus within from 1 to 10 days of life. Persistent patency beyond that point is generally permanent. About 85 to 90% of patent ductus arteriosus occur as isolated defects. The length and diameter, up to 1 cm, are variable. There is associated left ventricle hypertrophy and pulmonary artery dilatation. Also initially asymptomatic and notable only for a prominent heart murmur, described as machinery-like, long-standing patent ductus arteriosus induces pulmonary hypertension with subsequent right ventricle hypertrophy, and finally right to left shunting to produce late cyanosis. Early closure of a patent ductus arteriosus, either surgically or with prostaglandin administration in otherwise normal infants, is therefore advocated. Right to left shunts with early cyanosis. In these groups of congenital heart defects, we include tetralogy of Fallot, transposition of the great vessels, and truncus arteriosus. Tetralogy of Fallot consists of next defects. There are ventricle septal defect, dextrapose aorta overriding the ventricle septal defect, pulmonic stenosis with right ventricle outflow obstruction, right ventricular hypertrophy, and cyanosis is present from the birth or soon after. Diagnosis. Newborns often and children less commonly may be admitted with evidence of left side failure, indistinguishable from that seen in patients with large ventricle defects. These patients have only mild pulmonary stenosis at this time. Older children and adults with tetralogy of Fallot who have not undergone surgical repair almost never show evidence of congestive heart failure unless there are complicating factors: bacterial endocarditis, anemia, aortic regurgitation. They have cyanosis and exercise intolerance of varying degrees. They have moderate or severe pulmonary stenosis. They are cyanotic and have clubbing of the fingers and toes. After running, even walking, they may assume a squatting position. Hypercyanotic spells occur mostly in infant. This consists uncontrollable crying with increasing cyanosis, tachycardia, tachypnea, leading occasionally to unconsciousness and sometimes even to a cerebral vascular accident. The frightening part of these spells is that they may occur in otherwise healthy-looking pink infants. The conventional explanation, based on less than unassailable evidence, is that the attacks are due to infundibular spasm. Usually, these attacks occur in the morning and last from several minutes to an hour or more. Physical examination. Results of the physical examination of patient having tetralogy with mild pulmonary stenosis are virtually indistinguishable from those for patients with large ventricle defects. In patients with moderate to severe pulmonary stenosis, cyanosis and clubbing dominate the picture. A systolic trill may be palpable at the left sternal border, transmitting to the suprasternal notch, but usually not to the carotids. On auscultation is usually an apical click, large aorta, a single loud second sound, and great from 4 to 6 systolic murmur at the lower left sternal border, transmitting well to the suprasternal notch. No diastolic murmur is heard. Minor laboratory tests. Increased hematocrit from 50 to 75% is characteristic of cyanotic heart disease in children and adults. Severe polycythemia, unusual in infancy, may increase the viscosity of the blood to a level that would impede oxygen delivery to tissues. The usual manifestation of these are symptoms of the central nervous system: dizziness, headaches, blackouts. Electrocardiography always shows right ventricle hypertrophy, often associated with peaked P waves, P pulmonale. Radiography investigation. The film in a patient with a right to left shunt shows a normal-sized heart with right ventricle contour, boot-shaped like a Dutch wooden shoe. A large aorta, a right aortic arch in 20%, and normal or decreased pulmonary vasculature. The main pulmonary artery segment of the left border of the heart is diminished and may even be concave. The echo Doppler study demonstrates the subaortical ventricle defect and the infundibular stenosis. This established the morphologic diagnosis of tetralogy of Fallot. Cardiac catheterization with angiography provides the morphological and physiological details and is usually performed prior to surgical repair. Management. The treatment for tetralogy of Fallot is surgery. The questions remaining are the nature and limit of the operation. There are distinct indications even today for Blalock-Townsend shunts in the treatment of tetralogy of Fallot. Conus coronary artery, and as an emergency measure for severe hypoxic spells, not manageable by medical means. Transposition of great arteries. Origin of the aorta from the right ventricle and pulmonary artery from the left ventricle. The patient with transposition of the great arteries has two parallel circulation. Blood may recirculate repeatedly through the same side of heart before returning either to the systemic or the pulmonary capillaries. The unoxygenated systemic venous return passes through the right ventricle to the aorta and back to the systemic capillaries. The oxygenated pulmonary venous return passes through the left ventricle and returns to the lungs. It is obvious that the transposed circulation is incompatible with life unless there is communication between the two circuits, ventricle septal defects and atrial septic defects. Obstructive congenital anomalies. Coarctation of aorta is a narrowing or constriction of the aortic isthmus. It is a common, potentially fatal congenital cardiac malformation, clearly progressive through the years. 50% occur as isolated defects, the remainder with multiple other anomalies. Clinical manifestations depend on the location and severity of the constriction. Most occur less distal to the ductus ligamentum arteriosus. Postductal. Preductal coarctation manifests early in life and may be rapidly fatal. Survival depends on the ability of the ductus arteriosus to sustain blood flow to the distal aorta and lower body adequately. Even then, there tends to be lower body cyanosis. This form usually involves a 1 to 5 centimeter segment of the aortic root and is often associated with fatal right ventricle hypertrophy and early right heart failure. Postductal coarctation is generally asymptomatic unless very severe. It usually leads to upper extremity hypertension, but low flow in the lower extremity, causing arterial insufficiency, claudications called sensitivity. Collateral flow around the coarctation generally develops, with intercostal rib notching, noted on X-ray waves, and internal memory and axillary artery dilation. Management. The treatment of complex coarctation is surgical, resected and end-to-end anastomosis, aortoplasty, using the left subclavian artery, and balloon dilatation of uncomplicated coarctation. Thanks for attention.